Next slide, please. Next slide. So I want to acknowledge that the land on which we host this session is the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, the Tsleil-Waututh Nations, and the Métis Charter Community of the Lower Mainland region. And as spring is hitting the Pacific Northwest, I think we come especially to appreciate our tending of the land and the people on it, and continue to learn from it as we do today. Next slide. So Province-Wide Rounds is a collaboration between the University of British Columbia and BC Renal, proudly put on to make sure that we all are as up-to-date as we can to take the best care of patients that we can, and sponsored by our generous industry partners, but also participants from all across all the health authorities in the province, and really something that I think we've all come to look forward to on Friday mornings. Next slide. So really a great pleasure to be able to introduce Dr. Michael Shlipak to give his talk. I want to tell you a little bit about him. I've known Dr. Shlipak for a while, but he's the Associate Chief of Medicine for Research Development at the San Francisco VA Healthcare System. He's the Scientific Director of the Kidney Health Research Collaborative at UCSF and a Professor of Medicine, Epidemiology, and Biostatistics at UCSF. He graduated from Harvard Medical School and obtained his MPH from Harvard School of Public Health, and then he completed internal medicine residency in the general internal medicine in San Francisco. And his research activities involve the detection and determinants of kidney disease and its association with adverse outcomes, including cardiovascular disease. And he's really been a pioneer on the use of Cystatin C as a novel and, as you'll hear, perhaps a good indicator of kidney function, or GFR to be precise, and its potential to improve our understanding of kidney disease epidemiology and clinical care. And for that body of work, he was awarded the John Blair Barnell Award in 2018 from the VA Clinical Science Research and Development Service. He's the author of over 500 peer-reviewed manuscripts and has been on a number of different national and international guidelines for the diagnosis and treatment of chronic kidney diseases. And he's been continuously funded by the NIH for the last 22 years, which makes him older than I thought, and has been working also with the VA Health Services Research and Development Robert Wood Foundation. And Mike, I'll turn it over to you. I'm really looking forward to your update on Cystatin C as we begin our journey. And for one added piece of information, Mike is not a nephrologist. He's a general internist with an interest in nephrology and has been an outstanding partner to the nephrology community. So over to you.
Thank you. Thanks for the warm introduction. Let's see if I can share my slides. There we go. Let me go to the... Does that look right?
No, flip over.
Flip over.
Now it does. Yep, perfect.
It is? Okay.
Yeah, perfect.
Fantastic. Okay. So as you heard, the title of my talk is Clinical Use of Cystatin C in 2025. I do hope this will influence your practice. My disclosures, most importantly, I've never had any financial relationship with any company that's involved with Cystatin C. And although I am employed by the San Francisco VA and the university, I am here solely representing the UCSF, and my presentation and my views do not represent those of the Veterans Health Administration necessarily, or the US government. So this is the outline of our talk. I'm going to start by talking about GFR estimation and why Cystatin C has advantages over creatinine. Then we'll look at population data, where we can see how the two markers predict outcomes across large populations. And then finally, what do we do when the two markers don't agree with one another? And we'll go through some clinical cases. So I've been studying Cystatin C for a little over 20 years, dating back to the early 2000s. And I've been hoping that it would draw attention. And then right around 2020 and 2021, there was a large uptick of interest in Cystatin C. And that was initially driven by the concern about the influence of race with creatinine, and the National Kidney Foundation of the US and American Society of Nephrology advocated for increased routine and timely use of Cystatin C and removing race from creatinine equations. A few years later, the 2024 KDIGO clinical practice guidelines, which I'm sure you've heard about, led by our Dr. Levin, with my participation and those of many friends, have increased the recommendations around Cystatin C, and I'll get to that about the middle of my talk. So let's start with basic principles. So all of you are very familiar with serum creatinine. I think so familiar that I think sometimes we forget how limited it actually is. So creatinine has been with us for about 100 years. I think its use started in Germany. And they realized at that time that blood levels of creatinine were cleared through the kidney, and therefore higher creatinine in the blood represented worse kidney function. You all know that. And you also know that the production side of the equation, creatinine comes from creatine in muscle, and therefore higher blood levels of creatinine may also represent better health. And this yin-yang between creatinine being both a good marker in the blood, a marker of good health in the blood, and a marker of kidney dysfunction, I think we tend to overlook, especially in nephrology. You're mostly seeing patients with quite high creatinines. Because we are unable to estimate this production side, we've created these crazy workarounds, initially with age, sex, and race, now with just age, sex. But from sort of a basic principle, it's never really made sense at an individual level that if you know someone's age and sex, that you actually will know how much creatinine they produce. So that works really well with the math of equations across thousands of healthy people. But when you see an individual patient, you really have no idea how much creatinine they make, or creatinine they generate. And it's probably a lot less than you might imagine, because nephrologists generally see patients who are sicker than average. So as you know, creatinine may be misleading in many patients. When I talk to clinicians in the Department of Defense, they see these type of patients, special forces officers who are defined as having CKD because they have too much creatinine production. A heavy meat diet will make your creatinine go up, protein supplements. But what we worry about more is the large population of patients who are underproducers of creatinine, particularly those in the hospital, but older adults, inactive, amputees, those with malignancy, cirrhosis, HIV, even vegetarians are all going to produce less creatinine than the average in our GFR equations. And of course, there are medications that block secretion of creatinine and then falsely elevate it. So with all these influences, you wonder, why is it that we still accept creatinine? So why Cystatin C is better than creatinine in principle? Number one, Cystatin C, as you may know, is produced in all nucleated cells constantly. And so with the normal cell turnover that is present in all humans from about age 1 until the elder years, it's a pretty steady production of Cystatin C. It's freely filtered at the glomerulus. It's metabolized in the proximal tubule. And so there's no bias from muscle. There's no bias from health status, except a few specific diseases we'll talk about. And Cystatin C equations for GFR have never had race adjustments. This is the CKD epi equation from New England Journal 2012. It does have age and it does have sex. These parameters are much smaller than the creatinine equations. The European equation for Cystatin C has been developed with only age and with no sex influence. And so the bottom line is Cystatin C is just a lot less biased and requires less accounting for all the confounding factors that creatinine does. It's not perfect. Cystatin C is increased in certain situations. The big one is major high turnover states like leukemia, people who are thyrotoxic. I've seen a patient in my practice who had uncontrolled psoriasis, and it seemed to make their Cystatin C go up. Corticosteroids directly influence the genes that produce Cystatin C. We don't exactly know how much corticosteroids make cystatin C go up. That's a study to be done. But once someone's on a steady dose, that becomes less of a concern. Smoking seems to increase cystatin C, and obesity may bias cystatin C upward. And then situations where the cystatin C would be suppressed. Really, the only one I'm aware of is very low cell turnover, like untreated hypothyroidism. And clearly, there are far fewer influences on cystatin C than creatinine. And as a result, if we look at correlations of each marker with measured GFR, cystatin C has a tighter correlation. So this is the MDRD study this is a paper from 2012, although the study, I think, is from the late 90s. And the MDRD is the type of population where creatinine is as good as it's going to be. The mean age is 52, non-diabetic CKD. So it has a tight range of GFR, roughly like 20 to 60, and relatively healthy people other than their kidney disease. And so in that setting, creatinine accounts for 64% of measured GFR. This is 1 over creatinine. This is measured GFR. This is our R squared. In this same population, cystatin C, 72%. So even in a kidney population, cystatin C has a much tighter correlation to measured GFR. And you can see how most of the dots are within these red lines. Now that's in people with kidney disease. This is a study of ambulatory elderly people. This is the Berlin Initiative study. All had age 70 or older. And in this setting, creatinine's R squared for measured GFR has now dropped to 59%. Cystatin C still around the same at 75%. Now, this is 59%. Now, these are all 70-somethings who are ambulatory. They're healthy enough to volunteer for a 5 to 10-year protocol. Imagine how much lower this will be in people who are non-ambulatory, maybe nursing home bound, chronically ill. And unfortunately, those type studies, we don't get measured GFR in. This cuts to the more recent CKD-EPI equations that have removed race. And when we look at creatinine, the new creatinine equation, I think in BC, you guys use the old equation without race, as I understand it. But so this is the newer equation, the cystatin C equation, and the combined equation. So just looking at bias, the median bias, which is the difference of measure versus the estimate, cystatin C has the lowest bias. But when you look at accuracy, which is the proportion within plus or minus 30%, the combined equation gives you the most likelihood of getting an accurate estimate of measured GFR. And that's really, that's been the same conclusion across almost every study of ambulatory populations. The best GFR equation is the combined equation. And so that's really the first key point of my presentation, is that for the vast majority of healthy-ish ambulatory patients, the combined creatinine cystatin equation is most accurate. So this is not renal clinic. This would be your primary care or other specialty colleagues that if they want an accurate GFR, the combined equation for most people is the way to go. So now let's look across broader populations, and we're going to shift into more epidemiology type presentation. So when I started studying cystatin C about 20 years ago, we asked the question, how do we compare creatinine and cystatin C in much larger populations than we would get in a measured GFR study? Because measured GFR is kind of hard to do. Although it's considered the gold standard, it's actually somewhat imprecise. It has sort of a test retest of about 90%. So that would, so it's not as precise as either creatinine or cystatin C. Rarely available clinically, rarely measured in sick or hospitalized patients. And I doubt you guys use it a whole lot clinically. So we decided to think about what are outcomes that are related to CKD and to compare prediction with creatinine and cystatin C. So this is the first paper that got me really engaged with cystatin C. So this is a cohort called the cardiovascular health study, older adults, sample size of about 4,600. We looked at quintiles of sex-specific creatinine or eGFR. And not surprisingly to you, and this was already present in the literature, there's kind of a J shape where highest risk in the worst kidney function, second highest risk in the lowest creatinine area. And as you well know, these are probably the frail people because low creatinine in an older adult is probably more likely frailty than outstanding kidney function. So we looked at cystatin C and we saw this crazy linear association where both at the high end, we were capturing a much higher risk CKD group, but then this linear association in the normal, the presumed normal kidney function, is kind of a paradigm changer and really pivoted my interest. And I've been studying cystatin C ever since then. We looked at heart failure around the same time, J-shaped association with creatinine, very linear with cystatin C. And I spent about the next decade replicating studies using cystatin C in various cohorts, elders, general population, HIV infected. After about 10 years, we had enough data for a meta-analysis. And so this is now 2013. So a meta-analysis of 16 cohorts, 90,000 participants. And with this many people, every point along the eGFR spectrum becomes its own unit of analysis. The reference, and this study was conducted by the CKD Prognosis Consortium, which was based out of Hopkins at the time. I'm really just the front person. Relative to 95 as the referent, you see with eGFR creatinine, this J-shaped association where above 90, the higher your eGFR gets, the worse your mortality risk. Whereas with the red line being cystatin C, there's really no J shape at all. And the risk really begins around 90. So these are the thresholds. Creatinine risk begins at 60, and that's why we've generally called chronic kidney disease less than 60. With cystatin C, the actual point of 88 becomes significant risk. And the combined equation, which surprisingly to me at the time, is much more similar to cystatin C than I would have thought it might be more of an average. But the prediction by the combined equation is almost as good as cystatin alone. 10 years later, 2023, we now have 720,000 participants with creatinine and cystatin C. And the upshot, this has 8 different cardiovascular outcomes. Using creatinine, you still have a threshold of risk at 60. When you use the combined equation, the threshold is 90. And these findings went directly into the KDIGO 2024 guidelines. And second key point, cystatin C reclassifies stages of kidney disease and detects risk for adverse outcomes earlier and more accurately than serum creatinine. Now, as nephrologists, you're seeing patients over here, creatinine is still quite prognostic there. But the question is, how many of these patients between 30 and even 90 in sick patients actually have advanced CKD and you're not picking it up by creatinine? So I'm going to go through the kind of the highlights of the guidance in the 2024 KDIGO guideline related to cystatin C. There are 6 main topics. Regarding CKD staging, this is a pretty strong recommendation. If cystatin C is available, and I hope it will be in British Columbia, if not already, then soon, then GFR stage should be estimated from the combined creatinine cystatin equation. Now, this does not mean that every patient getting a creatinine needs a cystatin C. This could be once in 5 years. But if a patient is high risk for chronic kidney disease, such as diabetes, hypertension, heart disease, or they have a diagnosis of CKD, they deserve at least one cystatin C. For decision-making, a recommendation that we should use the combined equation in clinical situations if creatinine is less accurate and if GFR may affect clinical decision-making. Now, I will opine that any hospitalized patient, just about the creatinine may be less accurate. So if you are a hospital-based consultant, I hope you'll consider thinking about ordering a Cystatin C. Special populations, consider using Cystatin C without creatinine in certain circumstances. Bodybuilders are the quintessential big creatinine producers, but I think we over-imagine the size of the muscle. I would think a skinny marathon runner probably produces more creatinine than the average weightlifter. So it's really creatinine production and muscle turnover and not just the volume of muscle. On the flip side, paraplegia, amputations, those are sort of the quintessential conditions. But any elder who has a hard time ambulating is probably a underproducer of creatinine. So when the creatinine eGFR and the cystatin eGFR differ, it's suggested that we understand the implications of these differences as they may be informative, and that's going to be a big focus of the rest of my talk. Advice to clinical labs. We hemmed and hawed in the guideline between saying it should be an in-house test, because if it's not an in-house test, it won't be ordered, versus saying it's fine if it's a send out as long as people know how to order it. But one way or another, laboratories should make it clear for clinicians so clinicians can order the Cystatin C. And then finally, medications are probably where we think of GFR most as being clinically relevant. And so in difficult drug-related decision-making, where the drug has a narrow therapeutic range, toxicities, or the creatinine's unreliable, use equations that combine both creatinine and Cystatin C or measure GFR. So this is the current state-of-the-art recommendations. If you fall asleep at this point, you will have heard the international guidance. So now we're going to talk about practical use of Cystatin C. So the national VA has actually led efforts to adopt Cystatin C nationwide as of the last couple of years. So across the x-axis, these are calendar years, 2018 to 2023. Now at my hospital, we were one of 3 VA hospitals that had Cystatin C available before 2018. I've been using it clinically since 2012. And since 2012, we've had it as a routine test that comes back as fast as creatinine. All of our primary care, our nurse practitioners, our specialists are all familiar with Cystatin C and use it quite a bit. So since 2020, the VA became interested in making it available for all veterans, and you can see it's gone up steadily. And since we made this slide, in the last 14 months, it's more than doubled, 175,000 tests. And if you look, it's about 90% outpatient test. And so most of this is not inpatient. So just kind of our current use. Other healthcare systems, this is one major cystatin production company. They probably have 1/3 of the US market. They told us that over 3 years, they've had a 200% increase, so a 3-fold rise in tests sold. And interestingly, these are their other major markets. Sweden's a bit of an outlier because Cystatin C was discovered as a kidney function marker in Sweden, so they've always been high users. They're still increasing. And then Asia and South Korea, they use more than the US. In China, 2.2 million tests. And as an anecdote around cost, which I'll talk about on my next slide, I asked the sales rep, how cheap can you make it, and how cheap are you selling Cystatin C in China and still making a slight profit? And the answer was 60 cents. And so Cystatin C can be a pretty cheap test. And it shouldn't be expensive. In-house testing is far cheaper than send-out testing for Cystatin C if it's used somewhat routinely. So for people who represent laboratories who are in this seminar, as you know, when you start a new test in the lab, there are fixed one-time costs such as reagents for validation, staff training, IT infrastructure. And then there are the continuous costs that involve daily QC, calibrators, and things like that, that I say the words, but I don't actually know what they mean really. And so with all that fixed cost in mind, if you only did one test a week, it would be very expensive, and then you should send it out. But if you are measuring with some volume in your institution at about 1,200 tests per year, which is 3 per day, it's actually only $3 per test. Now that is the assay cost, but there's really no labor cost because all of these are automated systems where, you know, the blood specimen enters and all the tests are run without any specific labor time. At 10,000 tests a year, it's 27 a day. It goes down to about $2 a test. And that's about as cheap as it will get. At our hospital, we report the cost of all tests. Our enzymatic creatinine is $1.50. Our Cystatin C is $2.70 because we're at probably 5-6 per day, somewhere in there. And here's a reference that we just published that has more practical information for labs. Now, in contrast, many people talk about Cystatin C being really expensive, and I don't think most of us really know what other labs cost. At our hospital, for example, PTH is about $5, vitamin D is about 20, natriuretic peptides are about 25. So there's a lot in the literature that Cystatin C is too expensive for practical use, but I don't believe that's true. Okay, now let's shift to the differences in eGFR between creatinine and Cystatin C. And I'll preamble this with, if they always agreed, there'd be no point in ordering Cystatin C. So it's very reassuring when you get the same eGFR estimate for both tests, and that happens in my practice quite a bit, but it's interesting when they differ. So over the past, I'll say 4 or 5 years, we've been answering the following questions about how we manage differences between the two eGFRs. How often does Cystatin C substantially differ? Do large differences have clinical implications? Do you need to repeat Cystatin C over time? Is there any prognostic value, or is a one-time enough? And are there factors that predict large differences so that we might hone in on who we're testing? So let's start by just defining the eGFR difference. So in the literature by our group and others, we have operationalized a 15-point absolute difference. Others have used a 30% relative difference, but the subtraction and adding of 15 is easier than multiplying and dividing by 30%. So we've gone the easier route with that. So a negative eGFR diff is when the cystatin is 15 points lower than the creatinine. And as you can imagine, we see this in people who are more frail. A positive, a happy diff, is when the cystatin is 15 points higher than the eGFR creatinine. And active people tend to be in this category. So we started by looking at various populations and saying, how often are they 15 points apart from one another? So in ambulatory populations, this is a hypertensive trial of people at high cardiovascular risk, 30%. An elder cohort, they're really not frail. These are ambulatory elders, 26%. The CRIC study, CKD, persons with CKD, 1/3. UK Biobank is a huge population-based study in Britain, which is everyone's under 70, so mostly middle-aged adults, 30%. And then we looked in hospitalized veterans, and it was 43%. And these are the median eGFR creatinine and Cystatin C among people who are in the VA system who are hospitalized. Note that 60 won't surprise you, but an average difference or a median gap of 24 points, it's pretty striking. And when I'm on the general medicine wards, I'll tell you, this is every day. The average difference is about 20 points. Sick people don't make creatinine. And so there is a lot of hidden CKD that we pick up when we have Cystatin C available. And our house staff at UCSF, we have Cystatin C at all 3 hospitals as a quick turnaround test. That's the university, the public hospital, and the Veterans Hospital. All of our house staff are aware of this, and they order Cystatin C before I ask for it. So what do these differences mean for prognosis? So the way to interpret this is you already know what the eGFR creatinine is. So once you know that, this minus 15 to 15 group, we'll call that concordant. If the Cystatin C eGFR is plus or minus 15, that's neutral. If the Cystatin C is 15 points lower, that's the negative diff group. And if it's plus 15, that's the positive group. So for ESKD risk, this is from the CRIC studies. These are all persons in a large cohort study with chronic kidney disease. If we found that the Cystatin C was substantially lower and 80% higher risk of kidney failure, transplant, or dialysis, whereas happily, if the Cystatin C read 15 points higher, a 50% lower risk. And ESKD, remember, is usually defined by creatinine. So this is, I was actually surprised that this one was as strong. I was not surprised by the mortality findings, where a 3-fold mortality risk for those who have the lower eGFR by cystatin, much lower risk if the cystatin is higher, and then heart failure similar to mortality. So the next question we asked is, do you need to repeat measures over time? For a long time, we would say that, as long as the patient's pretty stable, once you have a Cystatin C and you know the difference from creatinine, you can probably just follow the creatinine longitudinally. But after this study that I'm going to show you, we actually think that repeating the cystatin at least annually is probably a good idea. So here we have patients in CKD, persons with CKD in the CRIC study who had annual creatinines and Cystatin C longitudinally. Our referent group are persons who had the same slope. Now, whether they were declining both together or stable both together, the markers told the same story. Now, if the cystatin got worse and the creatinine was flat, they had an 8-fold mortality risk relative to this group. And this is adjusting for risk factors, eGFR. And so why is that? And so this is double jeopardy. So these are patients whose kidney function is worsening and their health status is worsening, because in the setting, they're basically making less creatinine. So the eGFR creatinine is flat while their kidney function is plummeting. And that's about as bad as it gets. Conversely, if your kidney function's stable, but your eGFR creatinine goes down, this is a creatinine producing patient. The patients who are restoring health, they're making more creatinine. This is probably a spurious drop in the eGFR creatinine. They have 1/10 the mortality risk compared to this other group. So these were pretty shocking findings. And my third key point, the eGFR, cystatin, and creatinine are discrepant in many individuals, particularly hospitalized patients or sick ambulatory nursing home patients. This discrepancy is associated with adverse long-term outcomes, either in the positive or negative direction, and the gap may change over time. So then we looked at what factors predict large differences between the two markers. And this is the UK Biobank of over 469,000 persons. We started just by looking at race. So those who self-identified as Black were most likely to have a eGFR creatinine that's lower than cystatin. And that's not surprising because of the whole issues around Black race and creatinine measurement. The striking part of this study were the South Asians. So 8,000 South Asians in the study, over 40% had a cystatin C eGFR more than 15 points lower than the creatinine. And then when we looked at these persons, we found that the proportion of CKD, eGFR less than 60, was eightfold in South Asians based on cystatin compared to creatinine, and predicting mortality, heart attack, was much stronger for cystatin than creatinine. So this is sort of a wake-up call that we really don't understand creatinine and cystatin well in South Asians, but creatinine may really underdetect CKD. Interestingly, in East Asians, I know a large population in BC, they had the highest concordance of the two measures, but only about 1,700 persons, so a small proportion of this cohort. Next, we looked at all the other possible determinants of large differences, and the short answer is there are many. If you look at the paper, this is published now. Most of these are in the expected direction, such that if you have a low grip strength, the creatinine is lower. If you eat meat, the creatinine is higher relatively. Smoking and steroids make the cystatin seem higher. Trimethoprim makes the creatinine seem higher. The upshot is, with so many factors linked to either kidney disease or poor health, if you suspect a large eGFR difference, just measure cystatin C. There's no smoking gun risk factor that will answer this question for you. And when I say if you suspect, we're all internists. I'm hoping that after this talk, you will suspect and that your curiosity will lead you to order cystatin Cs. Finally, for this section of the talk, this is an amazing study from the ICU. So what happens to creatinine in the ICU? This is a study from the UK, 38 ICU patients who are healthy at the time of admission. So a healthy patient who goes to the ICU, think trauma, or some sudden event in an otherwise healthy person. And they had the foresight to not only measure creatinine and cystatin daily, but they did ultrasounds of the quadricep for muscle mass. They measured GFR at ICU discharge, and this is what they found. They found that every day in the ICU, your quadricep mass drops 2%. And every day, the creatinine declined proportionately with that ultrasound. These were long hospitalizations. The cystatin C was stable throughout hospitalization on average, such that day one, the eGFR was the same. But by the time of ICU discharge, the creatinine eGFR was over 30 points higher than cystatin. And the measured GFR was even lower than the cystatin, such that the creatinine eGFR was 59 points higher than measured GFR at discharge. I'm going to read the author conclusion because it's in British language, which I enjoy. Cystatin C detects clinically important changes in kidney function in survivors of prolonged illness, while creatinine is not fit for purpose in this context. My colleague and I wrote an accompanying editorial that we titled, "Should we really still be using creatinine in the critical care setting?" If you are doing consultations in the ICU, you might be doing a consultation on a patient with an elevated creatinine, but look around at the other patients, and I bet they have undiagnosed chronic kidney disease because the creatinine is not rising. So I'm going to show a few cases regarding creatinine and cystatin C. Our general approach, we keep the two measures separate. We don't have a combined creatinine cystatin that comes out in our lab, but we average the two. We split the difference for most patients, which averaging is about the same as the combined equation. If the eGFR difference is large, more beyond 15 points apart, we try to think of the individual patient and think, are there any conditions that affect one or both biomarkers? We know more about creatinine biases. And so when the patients are physically active and muscular, we might think the creatinine's misleadingly low. When they're frail, chronically ill, and inactive, we might think the creatinine's misleadingly high. But we know that the cystatin C is not perfect either. And so when we don't know, we either average the two, and we try to be skeptical of the cystatin Cs as well. We just don't have as much information about when it's inaccurate. Okay, a few cases. I think I'm okay on time. Yeah. Okay, so I'm going to show 4 cases, and all of them are common and examples of many cases that we see all the time. None of these are an exceptional, like, case report kind of a finding. These are the mundane daily practice of getting 2 GFR markers. So we'll start an ambulatory care case, an 80-year-old with multiple morbidities. He has hyperkalemia, but his eGFR creatinine is normal. It's over 60. His history is that he has persistent hyperkalemia despite holding the ACE inhibitor, no other evidence of kidney dysfunction. He has poor exercise tolerance. He's deconditioned, largely from his heart failure. He also has diabetes and hypertension. This would be a typical veteran with all these conditions. And on exam, it's pretty unremarkable except the AFib heartbeat, and he's got a lot of edema. He's sent to nephrology clinic. These are his labs, notable labs. The eGFR creatinine 64, but he's got, a low bicarb. He's got a high K. He's somewhat anemic. Kind of smells like CKD. And the cystatin eGFR is 40. This is every day in primary care. So the takeaways, we recommend measuring cystatin C in patients at high risk of CKD, especially those with other signs of CKD despite having a normalish creatinine, and misleadingly lower height creatinines we see in these conditions I've been talking about: elderly, immobile, low nutritional intake, and then medications that affect secretion and might give you the higher creatinine. Case number 2. This is a patient in CKD. This is one of our patients, really follows his labs, and he thinks his kidney function may have improved. He's 3B-A1, labs checked, showed his creatinine had improved, exams unremarkable, and these are his creatinines longitudinally. His eGFR went from 40 to 49, and he's wondering if he has done something to improve his health. And maybe he has improved his health because he switched to a vegetarian diet, and that may be wonderful for his health. But when you look at the eGFR by cystatin, it really hasn't changed. And the takeaway here is that eGFR creatinine may be improving or steady despite worsening health, and that can hide CKD or worsening kidney function. Now, this is a very benign example. Like, we love it when our patients adopt a healthier diet. I've had several patients who've developed malignancies, and the creatinine steadily drops as the malignancy progresses, and they get sicker and sicker. And I have to remind the clinicians that they don't, the eGFR cystatin may still be 30, and they need to stop using the creatinine as the pseudo-normalization happens by creatinine. So not always a happy change of diet occurrence. Case number 3, a 65-year-old admitted with rhabdomyolysis. eGFR creatinine is about 9. He initially presented with CKs over 20,000. His creatinine, this is a guy found down, on the street, sleeping up for a couple of days. Creatinine rose from 1 to 7 over 5 days. My colleague in nephrology was consulted. Should he have a catheter placed for dialysis initiation? But meanwhile, the patient was actually looking pretty good, feeling better, CK's improving, less pain. He's putting out plenty of urine. His K had peaked and was improving. Bicar had natered and improving. Cystatin C showed that his eGFR was actually about 63. Now, you're thinking as a nephrologist that we probably shouldn't be using the eGFR in a rapidly changing patient. But regardless of whether the equation is appropriately used, the cystatin C was pretty normal. And the key point is that creatinine derives from muscle breakdown, so it can be misleadingly high in rhabdo. And I'll say that over the last 5 years, more and more of my colleagues across the US, when their hospitals adopt Cystatin C and it becomes available, they get really excited by cases like this. And I get lots of text messages about, look what we found when we had Cystatin C. So hopefully you will find similar joy if you're not already using Cystatin C, that it's kind of fun to get second opinions on the kidney function. This is the last case I'll describe. 73-year-old with a prolonged admission for Pseudomonas infection causing aortic endocarditis. The patient had a ureteral obstruction with a nephrostomy tube that got infected, advanced CKD on admission. He was receiving cefepime, 2 grams BID. He'd been bedbound for the last couple of weeks, and he started developing asterixis, and there was a concern for uremia. He didn't have any liver issues where it would be liver failure, and yet his creatinine didn't look that bad. On exam, he did have asterixis. He did not have a rub, a little bit of acidosis, and in this patient, the Cystatin C eGFR was 18, quite a bit lower than the creatinine estimate. Again, this difference of 20 is almost average in hospitalized patients in our experience. And so the clinical conclusion was the asterixis was from the cefepime toxicity, and it went away when the cefepime was stopped. And so several commonly used drugs, as you know, this is what you do every day, require renal dosing adjustments. Consider using Cystatin C to inform more accurate dosing adjustments. Now, when the nihilist will often say, why does eGFR really matter? And it's really drug dosing that probably has, as I mentioned before, the most direct relevance for having where Cystatin C might improve practice. But it's been really hard to study. There just aren't that many medications that are used commonly enough. There's one study that looked at oncology drugs and found that Cystatin C use led to fewer adverse events. But the best data are really on vancomycin. And these are several studies have come out of the Mayo Clinic. This is a clinical pharmacist, Aaron Frazee, who has led some of these studies. And this just shows that it takes a few days to reach steady dose with vancomycin. And they did a study, sort of a pre-post, where they adopted the use of creatinine and Cystatin C for estimating the vanco dose and determined whether that would improve their hitting the target for the trough over the next few days. And so this is the design. They screened a lot of patients. They ended up with a sort of a quasi-randomized trial where 2/3 had creatinine-based dosing, and then 1/3 using the combined creatinine Cystatin C. And they found that the proportion who hit this is the ideal trough right here, was only 28% using creatinine, and it improved to 50% using the combined equation. And that was a highly significant difference. So vancomycin seems like the most evidence-based drug situation where Cystatin C can improve clinical management in the short term. So my last slide, the key points of my talk. So Cystatin C really is an inexpensive measure of kidney function that has advantages over creatinine. It has fewer non-GFR determinants. It definitely improves the diagnosis of CKD, the staging, prognosis, and it can improve dosing of medications that have narrow therapeutic windows. For most ambulatory patients, the combined creatinine cystatin equation is the most accurate, and guidelines suggest that we use this combined equation at least once, maybe once even in 5 years, to stage CKD. In the ambulatory setting, nearly 1/3 of patients have discrepant creatinine and cystatin eGFRs, and these differences have prognostic implications, and cystatin C is the dominant marker for predicting your patient's future. The proportion of hospitalized patients with discrepant eGFRs is much larger, shockingly high. And when the cystatin eGFR declines faster than creatinine, this patient's in trouble. And as I mentioned, they are probably having both declining kidney function and declining health status. Numerous factors account for these differences between the two markers. It's easier to just order cystatin C than try to guess whether the patient might have a difference, especially as the volume of testing leads to relatively inexpensive test. And I'm going to, my final statement before Q&A, we are internists, you are specialists, I am a generalist, but internal medicine is for curious people. We should be skeptical people, and we should not assume that the creatinine is correct. We shouldn't assume the cystatin is correct. We should get second opinions in our biomarkers, and our patients will benefit. So thank you very much. This is our Veterans Hospital is right here. This is looking across from Marin into San Francisco. All right, I'm happy to take any questions now. I'll unshare if I can figure out how to.
Yeah, that'd be great. Thank you. Thank you, Dr. Shlipak, for excellent talk. And I think this is something that we've been trying to advocate for and are getting there. But I think that you've given us some excellent clinical examples that help us to highlight and understand why it is that we should do this. Curious if there are any questions. Do you want to put some stuff in the chat? The other thing, while people are getting their hands up or Q&A, I think you'll remember in the guideline group, our patient said, if you have a better way of accurately estimating my kidney function, why wouldn't you do that? Yes. And I think that was the most powerful thing that I heard. Like when Guy Hill said that, I was like, yeah, why would you take a second-rate test instead of a first-rate test? Or so I think that is something we need to take on board. And we used to think that measuring the GFR with nuclear medicine, that's, if you're worried, that's good. That's way more expensive than cystatin C. Not to mention the footprint and everything else, but like that's not necessarily the right answer, right?
Yeah, there are bedside GFRs that are coming. I don't know that they've been tested as well as measured GFR, but the current standard doing it right, is a 4 to 6 hour protocol, where you do an infusion, and it's a fun test and research, but it's not a practical clinical test.
Right. Yeah. So Naomi's asking, so one of our patient partners who joined second that emotion, why wouldn't you do a test that tells me? Thank you, Tamara. So Naomi's asking, are there studies looking at relative GFR in the GLP-1 agonist? Flow study,
Yeah, it's a great question. The trialists have struggled with this because when people lose weight, on GLP-1s or the other new agents, the volume of weight is about 2/3, 1/3. It's about 2/3 adiposity, 1/3 muscle, and which affects both tests. It seems that cystatin C is a little better than creatinine, but I don't think we know definitively that monitoring kidney function should be one or the other. And I think right now the guidance should be maybe use both at least annually and take them with a grain of salt because every patient's going to be different in the body comp. What do you know about that, Adira?
Yeah, I just know that Kathy's doing the study remodel, so we'll have a better idea. And in the flow study, you remember there was a dip with the GFR, the eGFR creatinine, but there was no dip with the cystatin C. It was just a linear. So again, in clinical trials, you might get rid of the dip if there's other, it's sort of an interesting construct. Yeah. Janice Dion is one of our pediatric nephrologists asking a really interesting question. That given that cystatin C is metabolized in the proximal tubule, does it mean that it's less accurate or not accurate in people who have proximal tubulopathies like cystinosis?
Yeah, it's a great question. And when I first learned about cystatin C, I was asked about this by our renal physiologist here. And I don't think I know a whole lot more about it, other than because if one of the reasons cystatin C was not initially popular in nephrology is that there's no clearance. And so you cannot calculate a cystatin clearance using urine. In the patients you described with the proximal tubulopathy, there will be cystatin C in the urine at an abnormally high rate. I don't think that affects the blood concentrations. I know our pediatric nephrology clinic at UCSF is using cystatin C in all their patients, but that is 2 steps removed from my clinical expertise. But on a
Okay.
physiology basis, I don't think it affects the blood, only the picking it up in the urine.
Great, thank you. I don't see any more questions. Does anybody, let's just see. Oh, how readily available is cystatin C eGFR in BC? Well, you can order a cystatin C in British Columbia. It goes out of province, or it can be measured in some labs if you ask nicely. So it's not readily available. We're working with the lab physicians because there are 2 issues in getting a test approved generally, and one of them includes the famous billing code. Right. So yes, it can get done, but I think we're going to work. So it is available in cases, and we have used it exactly in the cases that Mike, where it's hugely discrepant, or we had a man, getting assessed for transplantation and start of dialysis, who's in a wheelchair, who's emaciated, and whose creatinine based GFR we knew was inaccurate, and we got the cystatin C to see like how off we were, that kind of thing. So it is available if you really need it, but I think, as a nephrology community here, and hopefully this talk will help us, I think advocating for it, and then using it wisely and demonstrating the difference that it makes, I think will be really important.
When we first made it available in 2012 here, we are a governmental hospital. So
right. Similar to Canada, yeah.
Fixed lab budget. And so we put real guidelines on its use, because the lab was concerned of either too much use, and that would be too expensive, and too little use, which means they did all the upfront costs for no purpose. And so we had a list of conditions that we did not restrict it to, say, nephrology or anything
right.
like that, but we had conditions such as frailty, high-risk CKD conditions, HIV infection, cirrhosis, where we knew the yield would be pretty high.
Right, spinal cord injury, that other kind of stuff, yeah.
But,
yeah, I mean, I think that there's all this caution, and one of our biochemists at one of the hospitals is able to do it. But again, from an equity perspective, we would like the whole province to be able to access it, or so we're just working on how best to do that. But
so Polewski in VA led national effort here. And so each VA region, which would be kind of a province level, there's 22 in the US, so it's kind of a province unit, has at least one hospital that measures it. But there was a study in Canada, I think maybe from London, where they looked at how many send-outs they were doing, and the send-out number of tests, they found that they got the cost down substantially. And I don't know if that was Amit Gargar who did that. I know Cello has also been interested in this topic.
Yeah, I think a lot of us have tried, and we've tried to make that economic argument, because as you say, like, it's really not about how much it costs, because if you do enough, the costs come down. So, and it's cheaper than the alternatives that people are using, that they think they're getting a better or different answer. So, it's very important.
The main argument is the equity question. I'm glad there's a patient in our community of this seminar, as you mentioned, with the guideline. It's just when you look at the basic principles of creatinine and the vast number of, 1 in 3 patients is getting the wrong answer.
Right.
And in the hospital, it's
worse. And in the ICU, it's worse.
Just pretending that we're doing the right. And I say we because most US hospitals aren't offering it either. We're just really doing a disservice, and we don't know how many adverse events. They used to talk about this tsunami of adverse events in hospital. That iatrogenic harms drive bad outcomes. But I think this is part of that. I realize you tell me when we.
We're pretty well. I wanted just to thank you for really super clear and really nice, and also for making it so real, because I think this is about do we pride ourselves on being good diagnosticians? When should we, and we should be questioning the creatinine. We start to question the creatinine in the ICUs sometimes, but not always. And I think that's certainly an easy low-hanging fruit place to start, I would think. And that would be one place, because then we get the drug doses right and we get everything else right, which is not that they're using GFR anyways, but the creatinine's misleading too, because it's staying stable, as you said. So I think there's a lot of places where this can be applied. I really think that it's been you presented it really well, really accessible. And I think we'll report back as to what we're doing and when we get it available. But there's still some unanswered questions, as you said, which makes an active field of research. But I think we can offer it clinically sooner than later, and I think do a lot of good.
Once
So
it's
yeah,
clinically, you won't, you'll find it hard to treat a CKD patient without knowing the cystatin.
yeah,
It's
no,
every CKD patient in our clinic. The uncertainty becomes unacceptable.
yeah, no, thank you very much. And thanks for reminding us that that's who we serve. So thank you very, very much. And thanks everyone for participating and listening. And happy Friday.
Yeah, thanks for inviting me. Thanks for attending.
Great.